So I'm going to complete the mental health farm. And I just like really want to do this thing. I'm already giving the presentation. I did one and like only a few people were here, but they want me to do it again. So this, I made 3 videos. With questions, but this is the content, and you can add that to that. I may post this later. Try to mute your phone, but you shouldn't mix any question. I just try to give you all that because somebody said they had a lot of these mental health questions. The board know that people are afraid of it, and they will give it to you. Look at it. This should be your friend. If you have an issue, every day look at it and do like a puzzle. In the morning, you drink a coffee and you circle each class of medication. If I ask you to circle SSRI right now, you should look at it and say, I recognize this, right? I recognize this. Do you recognize this? Do you? You have to, right? It's also an SSRI. If I said, show me an SNRI, well, this is one of them, right? This is another one of them. If I said, pick a second generation antipsychotic. So this should be your morning coffee. As you go through, it said, who is the second generation antipsychotic? Which one is it? I don't know. I can't find it. They are there. I know you know this, right? I know you know this, right? Yeah. If I said pick a TCA, you should be able to pick a TCA and look through and say, who is a TCA? You should be able to pick one, right? This is one of them. And this is another one of them. This is one hiding here. And if I said pick MOIs, you have to look hard to look for them. The first one is on top. But if you do this, yeah, you master them. The name, this is just the name. Get comfortable. Then you have to know specific content. So this is the way you can master them. And this is the way I can teach you so that it can become comfortable with that. You can, every time you do that, you say, oh, when you see the name and you know you've answered 50% of the question, that will put you in a place that you can say, oh, I know these guys, right? I know them. This is who they are, right? And so that's the first group. So this is the beginning. Now, let's go on all of them. This is like this is the way they will frame the question. Okay, the questions are not that hard. Which of the following assessment finding need further evaluation? Okay. The nurse is caring for a client who's been taking what? That. Fluvoxamine for 2 weeks. Which of this I need further intervention? Then you look at it, you have to know what this is. If you know what it is, the rest is easy. This is an SSRI. What did they cause? Key for psych medication is if you don't know anything at all about them, don't let this trap you. Okay? Most of them causes weight gain. Most of them causes sexual dysfunction. Okay, most of them causes insomnia. These 3 things take you with you everywhere you go. Some of them causes rash, whatever. Like these 3 things, you take it with you. It said, okay, rash, I don't know, but this is side effect of SSRI. Weight gain, yeah, number 1, right? Fever, no, I never mentioned the 3 things here. And bruising, it affects platelets. So they affect platelets, it make you gain weight, it causes rash. But this, when you have fever taking SSRI, you know it's serotonin syndrome. And therefore, that's your answer. And that's the way you should be answering these questions. You see, like, we'll do a bunch of questions. So this is the first question. It's gone, right? Same thing, same strategy, just for you to see what it, which of the following assessment finding require immediate intervention. That means you got to intervene. Client is caring for, a nurse is caring for a client prescribed finaxin per request. What do you think? Don't answer the question, figure out what this is, and then the rest is easy. It's an MAOI. Then you said, what is the worst thing about this medication? I was told again, hypertensive urgency. You should not combine it with SSRI. If you combine it with SSRI, you get serotonin syndrome. If you take it with anything that will increase your hypertension, you get hypertensive urgency, like Tyramine food. Therefore, I'll use water nasal solution when I get cold. Yeah, when you get cold and you go and buy those medication, nasal decongestant, yeah, they increase your blood pressure. When you have a patient whose blood pressure is controlled, come to the clinic and your blood pressure all of a sudden is 180/70. The next question you ask them, did you get cold recently? Did you take any? So this guy, I don't want you to take any nasal decongestant. So just use saline. So we're good. I'm not worried about it. NSAID for back pain, it does not affect your blood pressure too much. You order pepperoni pizza, yeah? There's something wrong with that thing. That's tyramine, a bunch of tyramine floating around. Therefore, that's your answer. And they stop what? Fluoxetine 6 weeks ago. This is the content you have to know. I'll tell you later. To move from what? SSRI to MOI, you have to wait 6 weeks. From MOI to SSRI, just 2 weeks. And he has done the right thing. So the right answer is ordering pepperoni. It's the wrong answer. So pepperoni is the problem, right? So that's the problem. Okay, that's the problem. So that's the way the question is going to be set. Same thing, right? Select or apply. Which of the following statement the nurse should include at discharge? A nurse is caring for a client prescribed with this. I did not give you information, straightforward. You have to know what it is. Then you can answer the question. Amitriptyline. What do you think it is? What is the problem? Which one the nurse should include? This is a TCA. And I call it TCA dance, right? He has what? The TCA dance. He has dermatitis. He has anticholinergic effect. Okay, he has neural problem. It gives you drowsiness and confusion. And cardiac is number one. Cardiac arrhythmia. And the E, you just do the evaluation. Evaluate this. Anybody who is on TCA, evaluate for dermatitis, anticholinergic, neuro, 17% cardiac, with cardiac being number one. And therefore, what is the problem? Discontinuous medication when your mood improves. No, negative. You don't do that. Keep on taking it, okay? Change position slowly. Yeah, orthostatic from the anticholinergic effect. Excellent. Drink 2 to 3 liters of water a day so that you don't get constipation, anticholinergic effect. Sugar-free gum daily. Mouth is dry. Excellent. Drowsiness is common. Excellent. This is select or apply. For your test now, if you don't know it, just leave it. Pick those that you know. There's 4 answers, so you may probably get all of them right. But don't, if you don't sure, just let it be. You don't have to be 50-50 anymore. You have to be 99.9 or 100.1 to pick that answer. So if you don't know, you just let it be. Just say, okay, I'm picking those I know, and then I move on. So 2, 3, 4 should be included in the teaching. They are anticholinergic side effects. What was the rationale for picking for sugar-free gum daily? Yeah, so that you can have saliva, you can stimulate saliva, candy, right? Your mouth is too dry. You keep your mouth wet. That's why you do that. Yeah, you don't want to. Your mouth is too dry, so you want to do that. So that's the 3 questions just to get you guys going, and then we start. Okay. These are the class of medication. You saw the list: XSRI, SNRI, TCA, MOI, mood stabilizers, antipsychotic, and benzodiazepine. That is why everybody is afraid of them, because they are a lot. But make it easy. Make it easy for yourself. Okay, make it easy for yourself. So we will start with the first one. So the first class of medication is SSRI. So it's for serotonin, selective serotonin. So they are selective serotonin receptor uptake, reuptake inhibitor. So reuptake inhibitor. All it means is it's going to increase your serotonin level. Why is all this thing happening? I don't want to go there, but I'll go there. So this is neurotransmitters. We have norepinephrine, we have serotonin, and we have dopamine. When you have mood disorder, you have depression, or any psych issue, schizophrenic, bipolar, there is dysregulation of these levels. Either they have too much of it for some people, for those who are high, and then like schizophrenic, bipolar, or depression, you have low level of them. So for depression, your level of this are low. And for you to really act normal, okay, we want these neurotransmitters to go here. And we need them. So we want to increase this level. This, we call them monoamine inhibitors. So to increase your serotonin, your norepinephrine, your dopamine, so that you can have this euphoric, your depression will go away. All of them will get better. We need to find something to increase those levels. That's why they are there, to block those levels from getting destroyed in your system. What your body is designed, if you don't need anything, I'll destroy it. So in order to increase serotonin, we want to prevent them from being taken up and getting destroyed. That's all. So that's why they do this thing. So let's see. So the first one is to prevent reuptake, right? They're preventing reuptake of this medication. So we have to increase those levels. There's only few of them. Look at the last name. That's the easy way to remember. Some of them don't have the same last name, but look at their surname. I call them their surname. Look at the surname. If you can find the surname, put. There's in one class of medication, there will be multiple surnames, right? So the few of them is the Lopram. Okay, so the first one is citalopram. I'll put them together and citalopram. This is first group. So they are the Lopram group. Then you have the cytine. You have a fluoxetine. Okay, paroxetine. This is another group. And then there's two that is like off the chart, citrulline. They just basically, you can't put them together, okay? And the fluvoxamine. So this is only 6 medication. You can't tell me you can't remember only 6. So don't look at all of them. Just say, I'm mastering SSRI. That means you have 6 medications to study. Only 6. These are there. The Lopram family and the sitting, and these two, they are the traps. You can't put them together. So that's the only one. The one they like to test, those are these 6 people. That's all. And then when you recognize the name, you just go to their side effect. That's all. They block all of this, but mostly the normal one, these people, they block only serotonin. So that's the only serotonin they block. So this is very important. They use it for depression. They use it for eating disorder. It can also be used for anxiety or panic attack. All these medication can be used, anxiety disorder. So you can use them. And they are the number one. Your first line of choice is this medication. The problem is it takes some time to work. It can take like 2 to 4 weeks for it to do it work. So that's, you have to wait. So you tell the patient, don't stop it if you don't, even if you're not feeling well. Just keep on taking it, it will get better. As the medication therapeutic effect, they are the first line agent. Okay, first line agent for depression. So that's what you tell them. Okay. Key side effect. Some people use 3S, the key side effects, sexual dysfunction. So your libido go down. This should go away for like 3 months. It should go away. If it doesn't, you can change the medication. If it doesn't. Weight gain, they're notorious. You gain a lot of weight. What do you tell the patient? Exercise. So if you see a question, exercise, and then they have answer choice, tell them to go to the gym. Don't tell me you don't know what they're talking about. They're just flipping the answer choice, and they want you to think. They gain weight, therefore exercise. You tell them to exercise, that's all. Join the exercise program. Insomnia. You stay awake all day. Do you want this patient to take medication at night? No. So take it in the morning. So take the medication in the morning. Okay. If you have insomnia, well, don't drink caffeine, man. Then you'll be like nonstop. You can't wake up, right? So those are the things when you see it, you shouldn't be like, don't say, I don't know what they have. You know it. Just figure out what they're trying to see, and then look at the answer choice and see if it makes sense. You can get withdrawal syndrome, so you got to taper. That's why you don't stop right away. You got to taper the medication slowly, right? Patient can be clenching their teeth when they sleep, and sometimes you can't open their jaw because of the clenching nature. That's bruxism. And it can be dangerous. It can affect the muscles of your airway and can be a problem. So when you see that, change to new medication. And then had a bite block. It's very important. That's one common side effect of this people. It affects their platelets, so they can have some bleeding issues. And the common side effect is GI symptoms. It's not a problem. That's why they have to take it with food. So most of them can affect GI symptoms, so take with food. Okay. This is all. They can ask you questions back and forth. They can look at it and say, hey. And then in the multiple, the SATA question, they'll just change this and then tell you, take the medication with food. Yes, GI symptoms. Okay, don't stop it right away. You can have withdrawal symptoms. Take it in the morning because you'll be if you take it at night, you'll be up all night. Okay. If you take it in the evening, you'll be up all night, right? You're going to gain excessive weight gain. You should go and do some exercise. Tell your wife or husband that your libido is going to go down. So they have to use something to get you moving. Yes, all these things is important, right? So that's what you tell them. And then the most important is the first 2 weeks. First 2 weeks is where you have suicidal ideation. So if I start SSRI, I come for a follow-up 3 weeks, 2 weeks later. The first thing you should ask me is suicidal ideation. If they tell you they feel much better, yes, I feel really good 2 weeks after starting medication. Yeah, you are in trouble, right? This is the patient. It's a B-sharp moment. Okay, you have to see this patient. I feel really good 2 weeks. That's suicidal. It's not something you should let it go. Okay, so that's that problem. What is the issue you should watch for? It's combination. So serotonin syndrome. Anything that has too much serotonin, if you combine it with it, you will get that. So no TCA. Okay, no MAOIs. Even trazodone. These are atypical. Okay, these are atypical antidepressant. So tramadol is a pain medication that has serotonin in it. Okay, the migraine medication, sumatriptan, they have serotonin in it. You can take it. Most atypical antidepressant, you can combine it with it. And of course, you know this, St. John's words, they can take it with that. Okay, so this is the key that you tell them. Okay, St. John's wort. You shouldn't, otherwise they develop serotonin syndrome. And what is that thing? Okay, what is that? I don't know what it is, but somebody said something about serotonin syndrome. Guess what? All it means is you don't have to memorize anything. Serotonin syndrome means everything is up. Literally everything. Okay, tachycardia, diarrhea. If I give you bradycardia, you know it's wrong, right? Sweating, right? All these things, you get headache. Hypotension is wrong, right? Everything has to be up. So when they give you a SATA question, yeah, you know, your reflexes, I tell you reflexes and reflex is like +1, you know that's wrong. This is a SATA question I've set right there. If I said if I give you this, I said patient with ferocity all of a sudden is taking sumatriptan, came into the emergency room with fever 104. What else do you expect? I expect tachycardia. I expect some diarrhea. I don't expect bradycardia. I expect sweating. I expect some headache. I expect what? No hypotension, no reflexes. Everything is up. So you don't have to memorize it. You just have to know what is the problem, and they will figure out. So that is the issue. Okay, so that's that medication. There is a movement. If you're on MAOI and you go to SSRI, all you need to wait is 2 weeks. But if you're taking SSRI and you go to MAOI, you need to wait 5 weeks. It takes a long time to break down the serotonin out of the system before you can start the MOI. So that's if somebody is on monoamine or oxidase inhibitor, they have to wait 2 weeks for a washout period. But this one, 5 weeks is the duration. Question. I guess you got to type. So, but that is everything about these kind of drugs. So that is the thing you have to know. This is everything about them. So for this question, this one is wrong. This one, headache. This one is wrong. This one is wrong. This is a sucker. I guess some people are confused. Serotonin syndrome. This is what I expect to see. Those have cancer. I don't need to see them. TCA is tricyclic antidepressant. So that's the first group of medication. So that's that. Only 4 of them, you have to be able to recognize them. The second one is SNRI. And you should know, but just by the name, they are affecting what? Serotonin and norepinephrine. So they increase those levels. As you can see, this is a problem. Therefore, you cannot combine even this with SSRI. There's only 4 medication. Venlafaxine. I'll put them together so that you can see. There's venlafaxine. That is brother. This is a trap. It looked like SSRI, but it's not. I don't know why it has a sitting name. Duloxetine is actually SNRI. And then there's this long name. Okay, no me. Not crepe. Not C. Not Pharm. These are the only medication in it. Only 4 of them. Only 4 medication. They increase serotonin and norepinephrine. That's all. And what is it used for? Depression and anxiety. Anxiety disorder. Only few side effects. That's what they're going to ask you, because that's what the SATA is going to be. Like I told you, GI upset. It's no brainer, right? Insomnia, no brainer, right? Sexual dysfunction. The same thing. That's why you have to remember the class of those medications. There's only 2 that is consistent with this SNRI. The only 2, they cause dizziness or blurred vision. And you cannot use it in glaucoma. It worsens patient glaucoma. That's all. That's these 2 medications. This is their problem. And then you cannot use it in kids. No, you cannot, but you have to watch for that. There's a high suicide in children and adolescents. So that's why you have to watch it. So if I give you a question, you should be able to figure out that, this is affecting what? Norepinephrine and serotonin. There's certain things you shouldn't combine with this medication. It's straightforward. I should not combine things that will increase my serotonin, right? So I should avoid SSRI, right? I should avoid MAOI, right? I should avoid TCA. Those are the bad ones. So you just have to watch for it. And then there's another one. St. John's wort. You shouldn't forget. It's also increases your serotonin, right? So you shouldn't combine it with that. They're very, very sedative, right? So If you remember this, I did a alternative medication, valerian root. People use it for sedation. Well, you can't take it because these medications are very sedative. And this is all that you have to know about this. The first three is simple, but these two, dizziness, glaucoma, and suicide, is key. What about weight gain? I already said it. Oh, I did not put it there. Yeah, so weight gain. I thought I put it there. Yeah, so weight gain. So that's everything about these drugs. Very straightforward for them. Let's see. Can you explain what again? The St. John wort is people take it for depression, but if you combine with SSRI, it's going to cause serotonin syndrome because it's going to do the same thing as serotonin. It increases your serotonin. So anything that increases your serotonin will be a problem. Valerian root is very sedative. People take it for sedation. And then when you take it with SNRI, they will get into trouble. I have a video, it's called alternative medication. He has all the name of it, all the medication. It's a pharmacology. You check my YouTube, you'll see it, and you should watch it. And he has all the alternative drugs and what they do. So this group is gone. The next one is these dangerous ones. It's atypical. They don't follow anybody. They just like a word, They do their own thing. Atypical antidepressant. There's like few of them. Okay, I'll put them together. Vilazodin. Some of them are easy. They have the same last name. Nefazodin, Don, or whatever you want to call it. And trazodone. Yeah, it's Don. It's not Dean. Trazodone. Okay, those are the three. Then there's a few of them. Bupropion. This you have to know this guy. They like it. It's board favorite. Bupropion. Then metazapine. So only 5 medication. And you have to know this. This is the number 1 class of medication. These guys have the last name and they all increases serotonin. And you can see they all do this a different way, but these guys mostly serotonin. And then you have to know that they're atypical for depression. They're used for depression. They are atypical. Okay, so this is atypical antidepressant. You have to take one at a time. Because each of them are specific. And if you don't know anything, this one, you have to know it. Okay, it affects dopamine and norepinephrine. And it's used for depression. It's atypical. We can use it for smoking cessation. It's very, very good. This is always used for that. This is Wellbutrin. People use it for smoking cessation. And guess what? The board is going to ask you that. Like I said, everything causes, most of them causes insomnia. So you take it what? In AM. Right? This is another biggie. Okay? Most antidepressant causes weight gain. This one, severe anorexia. What I'm doing, when I do this, I'm just telling you this is what they will ask you because that's key. if you know this causes anorexia, would you want to give it to somebody who is anorexic? No, because that's what they will ask you. This is an intervention, teaching intervention, or something you have to intervene. Somebody with anorexia, you give them bupropion, they're not going to eat anymore. No eating, they're not going to eat. So you should avoid it in eating disorder. This is key. It makes you too much energy, even though depression, we want to let you give you energy. This give you too much energy, like too much energy. You are just on top, which a mental health problem, they have too much energy. Maniac. If you give this patient to a maniac patient, you're killing them. They're on top. It will worsen their mania. So you should avoid in bipolar patient. You see what I'm trying to let you be comfortable. These are the things you don't have to memorize. You don't have to be afraid. I keep on seeing a text. Say, how do you remember? No. Just like look at it, and these are the keywords. These what they have to ask you. So too much energy. So I avoid it in bipolar. Those are the key, not the name alone. The name you figure out, but then the key stuff about them. Avoid it because they will ask you, they will trap you. Okay. And then the third one. Okay. Third one. It decreases your high risk for seizure. Okay. It causes too much seizure. And so you should avoid it decreases your seizure threshold. So somebody who have a seizure history, yeah, avoid it in them. Somebody has like brain injury before, or somebody who have seizures, yeah, don't let them take this medication. It comes in, this is why they like it. There's a reason why I'm doing it. This is the why they bought. There's so many things about this drug. If you don't know anything about this, it comes in sustained release. So you got to tell them, don't chew it, don't cut it, don't crush it. Otherwise, they're going to get seizures. You'll get a lot of release. So don't do that. Why do we like this medication? Key, no sexual dysfunction. Right? You see, it's not freebie. You have no sexual dysfunction, so I want it. But guess what? So many things you should pay attention to, right? It make you anorexic. So if you have, you can use it for weight loss, right? If you obese, I can give it to you, and then you stop eating. So there is no weight gain issue with this medication. But your seizure threshold, you should avoid it in certain people, bipolar, and you can use it for smoking. So it's very good. I mean, it's a very good medication. And then the other bad, it takes like 2 to 4 weeks to work. So you have to pay attention. And then finally, it's a suicide risk associated with it, like every antidepressant. You got to evaluate for that. But that is bupropion. I don't want you to forget this medication. Remember, it's not alcohol. They will trap you. It's smoking cessation. It's used for depression, okay? Because it's what do they call it? Insomnia. You take it in the morning. An anorexic patient, don't give it to them. Otherwise, they will stop eating. So you should give it to somebody basically, you shouldn't give it to bipolar a patient either, because then you're going to worsen their problem. You should teach them about the sustained release, but there's good aspect. There's no sexual dysfunction. There's no weight gain associated with it, and it takes some time to work. That is that medication. Okay, so that's ibuprofen. Okay, so that's the first one. The second one, it does not have phalazodine. Serotonin, they all affect serotonin, right? So you should avoid it in SSRI, SNRI, MAOI. Basically, all the things like, is dangerous. And the only thing I would say is the same thing: weight gain, sexual dysfunction, weight gain. I can't keep on writing the same. Sexual dysfunction, insomnia, all those things. You should avoid. The only thing I would say about this is grapefruit juice. It will increase the toxicity of it. This is the only thing you need to know about it. But just know that it's a serotonin, because when they ask you a question, you have to know that it's a serotonin, so that when they combine it with something, you know that something is wrong. And that is all, velazodine. His friend is also the same thing, nevazodine. Guess what? Block serotonin. It's the same thing, right? The same weight loss issue and everything, we've talked about it. But there's only one thing that this one is very good at. If you take it with food, within 1 hour, everything is absorbed. So it's very good to take it with food. You can take it with food, it get absorbed so quickly. But otherwise, the same thing. Avoid MOIs, because you affect serotonin level. Avoid SSRI, and then SNRI. But they say I have insomnia issue, the same thing. Weight issue, those are the same. Sexual dysfunction, they do the same thing. So I'm just giving you the key for each one of them. Otherwise, they all do the same thing. Trazodone. This one, you got to pay attention. Because he has a lot of stuff. Serotonin, the same thing. That's what he block. Therefore, you got to avoid other things I've said. But what is the biggest benefit of this? This one make you sleepy. So excessive sleepiness. What do you think is the benefit? It's excessive sleeping. It make you sleep. The other ways, all of them was causing insomnia. You don't sleep. This one is good. So this is what we use, sleeping aid. You can use it for sleeping pill. So this is good. When do you want to take this? Guess what? Your body is going to ask you, when do you want to take it? I want to take it in the evening so that I can have a good night's sleep. So you take it in PM. This is the one you have to take it in the night, because it's very, very good. It's very good. When you take it in the night, you can have a sleep. The other thing your body like is this: sustained erection over 2 hours. And this is what PrEP is in. Well, this is B sharp. Because if you don't do anything, they're going to lose the alarm. The alarm is the penis. So you don't want this guy to lose his penis. So emergency. Somebody taking trazodone with the sustained erection is a priority. This is a B sharp moment. That patient you got to see. You have to see this patient. Okay, sustained erection. So that is it. But it's also used for night sleep. So you can have a night sleep. You take it in the evening. Others, you take it in the morning. That is the only difference. And you have to avoid grapefruit juice with this one too. Grapefruit juice is never good. So when you see it, just don't say it's a bad stuff. And the last one on this atypical guy is this one. Metazepam. This one, it blocks norepinephrine and serotonin. So it's different. Same story, right? Weight gain. Sexual dysfunction. But it's very less. So this one is less sexual dysfunction. The key also is excessive sleepiness. Therefore, take it in PM. This can be used to treat insomnia. The same thing. So that one and trazodone, you see older patients are always on this. We give it to them because they can't sleep, and then it helps with that. Guess what? You don't get anything free. That trazodone and that, they causes excessive sleepiness. When you study in pharmacology, you don't have to study it in separate. So they causes sleepiness. Well, any downer you can't take any downer. Downers make you sleep. So alcohol, avoid it, right? Benzos make you sleepy, right? So you have to know when you see that, you should be thinking something that make me sleepy. Why would I have to take something that will make me sleep more? I get into trouble. So when you see a question like that, yeah, it's just basically trying to see what you know. And that is atypical. You see, they're very important. They have special names. Each of them do what they have to do, but then you have to pay attention to their specific problem. Okay, so that's those ones. TCA, so tricyclic, antidepressant. Easy to remember them because they have the same, a few of them have the same name, but in the different group. The priming family. So there's the priming family. Okay. The primary. Yeah, desi. When you see it, you know that that's what they're talking about. The priming and chloro. Priming. Those are the four primary. Easy. Then we have the triptyline family. No, triptyline. Triptyline. That's the triptyline family. And there's this weird one. That's a pain. That's what you think they will give it to you. Like sometimes if they want to make it hard, if you're getting this, that means they're making the test hard. Doxepin and amoxicillin. So I have that's why I make a YouTube shot on that amoxicillin. It's a nice drug. It's very powerful, but it has different name, and so you can get confused with it. So this is it, amoxicillin and doxepin. So those are the other family, the tricyclic. What did they do? This one you have to know them because they like them. They affect norepinephrine and serotonin. It takes about 14 days to work. Sometimes it takes it, and you can take 4 to 8 weeks to get a full benefit. We use it for depression and anxiety. Sometimes panic attack. Why is this dangerous? Because it's a TCA dance. Why? Side effect, dermatitis, not the problem. Anticholinergic, not the problem. Neuro issue, drowsiness, not the problem. Cardiac arrhythmia, problem. So red flag here. And E, you just have to evaluate. So that's how you can remember the side effect. This is all the side effect. It also causes orthostatic, severe orthostatic, but I don't want to put that orthostatic hypotension is because of the anticholinergic issue, right? So orthostatic hypotension. So you have to know these issue and you have to figure out anticholinergic, like dry mouth, right? Dry mouth, urinary retention, constipation, okay, pupillary constriction, right? No, dilation. So they have a blurred vision, which is a priority. The vision problem is a priority. The rest is not an issue, depending on what is your condition. So expect them to, ask you questions in the SATA form, but you have to think about, they're talking about this. Sugar free candy, eye drops, fiber, drinking a lot of water, taking the medication. This is key. If something is going to cause your urinary retention, you should avoid before taking the medication. If you see that it's not a trap, it's a good idea. If I'm going to go into urinary retention, I need to pee before I take the medication. If you see that answer, yeah, that's what they're trying to get you to. Okay. So those are the side effects you have to know. You got to figure out what it can be used for. So many other things too. Back pain, okay? Back pain can be used for neuropathic pain, maybe fibromyalgia. It can be used for that because they have those side effects. They can help with that. So pay attention to that. And those are the side effects. The cardiac arrhythmia is number one. Anybody on TCA, would you check EKG to make sure they're fine? Contraindication, I already given to you, but if you have not said it. Problem, if you have BPH, I don't like you because you make my BPH worse, right? If I have glaucoma, angle, closure glaucoma, yeah. You're going to make it worse. It's a B-sharp moment. That's high problem, right? It's a B-sharp moment. That is a high problem, right? And you should avoid it in like MOIs. Hypertensive urgency. All those things you should pay attention to, and it can increase your seizures. So you can get some seizures from that. The problem is if you have high risk for suicide, we only give you We don't give you a full supply. We give you 1 week supply and you come in every day. These are the most common drugs they use for suicide. You look at it. It put you in an anticholinergic state. It makes you drowsy. It puts you in cardiac arrhythmia, slowly bradycardia, and then you're gone. Peaceful death. And therefore, we don't like taking it. We give it to people. So you have high risk of suicide. I don't want to give it to you. I'll give you just one week every time. And you have to come in so that I can check you. That is TCA. Those are the drugs. They can ask you in the case form, the client took this medication, you don't know, he came in, all the symptoms of anticholinergic, you should be able to figure out this is what they take. Classic question. What is the main use? Depression and other symptoms I've told you. Back pain, sciatica, fibromyalgia, and neuropathic pain. It's a depression medication. Main uses for depression, secondary uses fibromyalgia, neuropathic pain. You heard it before. They call it Elavil. This is the same thing as Elavil. That's amitriptyline. That's the same medication. So those are those medications, very dangerous. Then monoamine oxidase inhibitor. There's only 3. No, 4. Phenoxin is number 1. That is the prototype, easy one, right? I like this because it's easy to pronounce it. Selegiline, right? Then there is the isocarbazide. And the last one, yeah, cypomine. Only 4 of them. Only 4 medication in this class of medication. There's only 4. Like I said, you got to memorize them. Look at them. Look at the first screen. Go back to them and circle it and see if you can tell if this is one of them. So these are only 4 of them. That's all. You take 4 at a time and just figure out what they are. They all do the same thing. You don't have to worry about it. It's monoamine. That means all the neurotransmitters. So serotonin, dopamine are all affected. This can take some few weeks to work, like all of them. What is the biggest problem? Well, it's used for depression. It's used for anxiety. It's used for eating disorder. The same thing we're talking about, PTSD, panic attack, all of them can be used for. But what is the issue? I forget, sometimes most people don't put this here. They also causes release of tyramine. That is the problem. So this is why you avoid tyramine food, because tyramine is a form of neurotransmitter. So the causes released of tyramine. Therefore, you should avoid anything with tyramine in it. And the way I remember it, if the thing is aged, I don't like it. If the thing is fermented, I don't like it. I'm not good at food, but they will give you food. If the thing is smoked, yeah, yes, tyramine. That's the way to remember them. But you can go to Google, type tyramine food, and it will give you a list of it. And then look at it and memorize some of them for your test. I'll give you a few, but it's not inclusive. So if you know some, yeah, that's fine. But I give you the three things I usually like to memorize it. If the thing is aged, it's not fermented and smoked. So I'm looking for something that is old, fermented, and it's smoked. That's all. So if they give you a multiple choice, yeah, that's which one is this? If you think it's not aged, don't pick it. If it's aged, yeah, pick it. So aged cheese, right? Pepperoni, salmon, yeah, figs, banana, smoked fish, soy sauce. Like you said, beer, some red wine. If you go online, you see a bunch of them that um, you may know more than I know, but if you have a list, chocolate, sometimes and people call chocolate, all of them is one of them. Yeah, chocolate is one of them. So there's a list, a bunch of them. That's all. So avoid them. But this is not the problem. If you're taking the test, watch for this. Okay. You have to let the patient sign a consent, assess them for compliance. If they can be compliant with the medication, you should not give it to them. And you have to provide list of food. Don't tell them go and don't eat anything that has tyramine. I don't even know what is tyramine. They have no clue. Give them a list. The hospital should have a list with everything because if they don't do that, if they take it, they are in trouble. So they need to have a list so that they can look at the list and say, okay, yeah, this is what I should avoid. Otherwise, they can go into hypertensive urgency. It's a problem. So if they take it and that happen, you can treat them though. You got to block monoamine. The number one medication we use for blockage is phentolamine. It's the same thing. Somebody is getting epinephrine and they get extravasation. You use the same medication. It's a vasoconstrictor, so that will help with that. Phentolamine, or you can just give them nifedipine and drip, and that will help with their blood pressure. These people has to be in the cardiac monitor. You may have to support them in their respiration. You should avoid nasal decongestant because that also will increase your blood pressure. You should avoid SSRI. You should avoid TCA. There is some conditions that you should avoid this in. So these conditions, it's like if somebody have a cardiac history, yeah, CVE, yeah, cardiac history, you should avoid it. Pheochromocytoma. This is make your blood pressure really high due to release of monoamine. So they should not, you should not give it to them. This is everything about these drugs. And then the way to trap you, they will give you this and they'll compare it to another one, or they will tell you the patient is eating some thiamine food, or they go and eat some nasal decongestant. That's all. They don't have any question to ask you on. You combine it with SSRI or TCA, or you go and eat this food, or they go and take some cold medication. That's all. There's nothing they can ask you about this drug. You just have to know that this is TCA. Why do you need a consent? Because they can die from it. They have to be consent to tell you that, hey, they're going to take the medication and they're going to be compliant. It's a consent. You're going to take this medication. It has very dangerous side effects, and you're going to remain compliant. So if they can't do compliant, you cannot give it to them. you may change it to another medication. You don't want to give MOI in somebody who is non-compliant. You go and eat some pepperoni. They have, you go and buy some McDonald's. Oh, no, McDonald's. What is that? They said pizza place. You know, I don't know. I forget their name. But they go to the pizza place and enjoy themselves, and then they get into trouble. So you want to avoid that. Domino's. Okay, yeah. Somebody help me out there. Oh, they go and eat hot dogs. Yes, you know, it's bad. So those are the medication. After the mood stabilizer, we take like 5 minutes break, 10 minutes break. Then the next group of medication is mood stabilizers. Why do I call them? They use for bipolar. But most of them are what? Anti-epileptic. I don't call them like that in when you're doing psych. Just when you're doing psych, call them mood stabilizer because it stabilize your mood. And so don't only study lithium. Don't think lithium is the only thing that is in the world. There is a mood stabilizer, bipolar disease. They use for bipolar. Once again, they say bipolar means you have depression plus mania. So this medication is used for it. It's very, very important. And there's few of them. If you study them once, you know them. Lithium, valproic acid, they will use valproate. It's the same thing. Carbamazepine, lamotrigine, oxcarbazepine, toporamate, that's Topomax, and phenotine. You know them already. You have to know them anyway for seizures, right? I will just pay attention to, that's the one I'll talk about. This one, valproic acid, carbamazepine, lamotrigine, and that. This one, we don't use it that much, but these are the four we use it in addition to lithium. But they are all mood stabilizers. They stabilize your mood. Yeah, it's to calm them down. They stabilize their mood, calm them down. So you have to know lithium. If you don't know any of them at all, lithium, bipolar, acute mania. Okay, and that's what we use. Mostly that's what we use it for. It's very, very important medication that you have to know for your board. What is the good aspect, that something that you have to know is the side effect and what happens if you screw that. That's all. That's what you have to know about lithium. It has narrow therapeutic index. You have to know this number, 1.6 to 1.5. This is the normal. Okay. If it's greater than that, it can go to 1.5 to 2. This is like mild form. You see patients like tremor from it, the side effect. If it's greater than 2 to 2.5, this one, they develop seizures. If it's greater than 2.5, they are in coma. This patient's in coma. So, but you want to keep it to like 0.6 to 1.2. That's your key. That's the best area you want to get it to. Otherwise, we get into trouble. What is the problem? Lithium, has a lot of side effect. It's a salt. And it's very smart drug. It affects your kidney. And it causes the kidney to increase the lithium level by exchanging it with sodium. And then it affects the kidney to have diabetes insipidus, called nephrogenic diabetes insipidus. I'm trying to explain it to you why this is very important. It's very good drug. So in order to increase himself, it causes all these problems. It causes the kidney to lose a lot of water so that his concentration will be high. It causes the kidney to lose some sodium so that it can exchange it with sodium. And then when you take NSAID, NSAID increases the concentration of that. You use it to exchange it, like NSAID. So this is all that you got to pay attention to. This is how this drug is bad. Therefore, you should avoid anything that affects kidney. Anything that affects your sodium, okay, and those are the things, and anything that affects your fluid status. That's why you should avoid hydrochlorothiazide or diuretics. Example is hydrochlorothiazide. What does it do? You lose your sodium and you lose fluid. Lithium, love it. NSAID. Lithium, exchange it with it. ACE inhibitor. Lower your sodium. You see, so this is how it causes problems. So if I said I'm on lithium, I should avoid all these problems. Otherwise, I'll have toxicity. And it causes, I told you, diabetes insipidus. But it's called nephrogenic. That means they're going to lose a lot of water. You should know diabetes insipidus right now. That you're losing a lot of water. The urine is all diluted. You have no ADH. It's not like they don't have ADH. It's just the lithium causes that. Therefore, this patient need to drink a lot of water. This is why they have to drink 2 to 3 liters of water a day to avoid that. So these are the things you tell the patient: drink 2 to 3 liters of water, avoid NSAID, avoid diuretic. And the key, exchange the sodium. In order to avoid excessive exchanging of sodium, what you do is balance sodium. Don't increase it or don't decrease it. This is trap. Your body like it. I give you lithium, go on low sodium diet. It's wrong. Go on high sodium diet. It's wrong. What you do, maintain your sodium. Make sure you're eating enough sodium. Daily requirement of sodium. Don't go up, don't go down. It's like same thing in vitamin K. Okay, that's why they like it, to trap you. Don't go up on it. Don't lower it. Just eat the same daily requirement that you need. Just make sure it's normal as much as possible. Because if you give the body so much lithium, salt, what is there? I told you, your body exchange it with the lithium and you get lithium toxicity. If you have lower level, your lithium level will go down and then you go into maniac. So does it make sense? When your sodium is low, you go in maniac because there's no sodium to exchange it with lithium. When you have too much sodium, you can exchange it with more lithium and you get lithium toxicity. This is why, that's why it makes sense. So balance your sodium. Don't go up on it. Don't go, the same thing, the digoxin. Make sure your potassium is normal. Make sure your magnesium is normal. Make sure your calcium is normal. Don't go up on it, and though, because they like it, they will trap you. They will give you a bunch of subtle questions. Hey, increase your sodium, lower your sodium, and maintain it. Which one is the right answer? Maintain that sodium and don't go up on it. And that's all. Don't freak out if you see, hey, check your thyroid level because it causes hypothyroidism. And what do you give the patient if they develop hypothyroid? What do you give them? What do you think? Levothyroxine. So they will develop hypothyroidism and you have to give it to them. So if they see a Saturn, they say, check your thyroid. Yeah, don't say, hey, I don't know what it is. If they're female and they're going to have a baby, we have a problem. It's a teratogenic. So we have to wear some condom, okay? Birth control is not enough. You can combine it, OCP and condom, but it's a teratogenic. I don't want you to have a defective baby. So teach them to wear protective condom. And then if you see a question, it said, hey, you have to come for a lab draw. It's because of this. Frequent lab draw. This is all you need for lithium. Everything that they can ask you, I've just gone every place. Side effect. And I left the best for the last. What did I leave? GI symptoms. They're going to trap you. They're not going to tell you somebody is taking lithium is in seizures. Negative. They're not going to tell you somebody is in lithium is confused. No. They'll tell you GI number 1 symptoms. Tell you is having diarrhea. Red flag. Nausea. Red flag. Vomiting. Red flag. Not taking any PO because he has nausea. Red flag. I'm seeing that patient. That is your B sharp moment. This patient needs to be seen. It's a priority patient. Lithium, you have diarrhea. I'm seeing you. I can't wait. If you wait, they go into seizures. So you got to see them before. So GI symptoms is number 1. Confusion is wrong answer. GI symptoms. Diarrhea, yes. So those are the things you should pay attention to. GI symptoms. Number 1 for lithium. That one is gone. The 2 mood stabilizers. How do they work? It's because of this GABA inhibitor. They inhibit this, is an inhibitor in your system that puts you down. This is the neurotransmitter that lower your emotions and everything. So they improve, they potentiate the effect of GABA, if they ask you as a straightforward question. And it's used to treat mania. Okay. And it prevents it. It can also be used for depressive option of the bipolar. There's a bunch of them, like if it's 4 or 5 of them. You have to know all of them. Carbamazepine. This is the same as the one you already know for anti-epileptic. This one too, we have to maintain it a certain level. So you need a lab draw. And then you should not forget the side effect. Okay, common side effect, nystagmus. Don't worry about it. You have some vertigo. Yeah, it's a safety problem. Don't worry about it. You can have double vision. Don't worry about it. What you should worry about is this one. Pancytopenia. What does that mean? Your platelets, RBC, and white count all low. So if they say it causes granulocytosis, yes. But the true definition is pancytopenia, everything. So they have a bruising, They have risk of infection and they have anemia. Everything is down, carbamazepine. That's what it causes. So pancytopenia, that's the right word. It can cause granulocytosis because the white count is low. Neutropenic, basically. But they don't like to use it. It's pancytopenia. It's also teratogenic. So you know what to tell the patient, right? You got to wear barrier method of contraception. Keywords. You need some lab draw, right? It's a sulfur drug. All these mood stabilizers, except lithium, they are sulfur drug. If you watch all my videos, you know I like sulfur drugs. Sulfur drugs, they cause photosensitivity. Don't worry. Teach them to have a sunblock with the factor greater than 15. Number one, most important, is Stevens-Johnson syndrome. If they take the medication and a small purple rash on their chest, yeah, don't say it's a rash. Oh, just this is B sharp. You need to see this patient. Carbamazepine, and I have a small purple rash on my chest. That's B sharp. Stevens-Johnson syndrome. You have to see that patient. You also affect your liver toxicity. And of course, grapefruit juice, all of them, avoid it. It makes Coumadin not effective. You cannot combine it with Coumadin. This is carbamazepine right there. Keyword, pancytopenia. It can cause photosensitivity, and Stevens-Johnson syndrome may affect your liver, and it's teratogenic. You got to wear some condom. The next one, it does not have too much lamotrigine. If you watch my, I think I have a video on it. I made a questions on it. Lamotrigine. This is also a mood stabilizer. Okay. Also, oral contraception is ineffective. You got to wear condom. I'm giving you the key fact of all of them. Okay. Because it's GI symptoms, you got to take it with medication. Double vision. This is key about this problem. Therefore, they cannot operate any machinery with that. Blurred vision. It's also a sulfur drug. You know what to say, tell the patient, right? And it's a teratogenic. Because it's cleft lip. But that's the only thing. The key thing is double vision is number one for this one. But it's a sulfur drug, it's a teratogenic, cleft lip, and then oral contraception does not work. So you got to use a barrier method. That's lamotrigine. Valproic acid. Is also the same. Lab draw, 120 mics. This is the range. The same story, right? GI symptoms. It also causes liver injury. Oral contraception does not work. It's a teratogenic. But what is the key about this? Is what? Thrombocytopenia. Thrombocytopenia, mostly platelet issue. And pancreatitis. When you see that, yes, this is classic. So if they're going to ask you something special about this drug, this is the way they will ask you. So that's the way they will ask you that. Pancreatitis is classic. When they're going to ask you about that specific medication, it's what is known for that medication. So that's what you can use it for. So you avoid, it causes thrombocytopenia. cytopenia, and then pancreatitis is the most common side effect for that drug. And then the last one, you probably have heard about it before, so I gotta clean this. It's phenotype. It's also anti-epileptic, but it's very, very good for mood stabilizers. Of course, 22 mic. Most bad medication at 20 mic, that's the level you want to keep it. What is the major side effect? Not nystagmus, like it causes a it's not nystagmus because all of them can cause nystagmus, right? And this one is horizontal nystagmus. Not the it can cause this ataxia, like lithium is not the biggest problem. It can cause gingival hyperplasia. Don't see this patient. Don't freak out on it. Don't pick this as an answer unless they are not asking you about B-sharp movement. This is normal. It's found in younger kids, less than like 25 years old, if their dose is greater than 500. So all you need to do is decrease dose and send them to discuss about oral care. It's not a B-sharp movement. Don't worry. Gingival hyperplasia taking phenotime is not a problem. How do you treat it? How do you prevent it, guys? What would you do? Yeah, you can take a picture. That's fine. How do you treat gingival hyperplasia? How do you prevent it? What do you give these patients? So there's something you can give them easy. Oral care, yeah, it's fine, but we can give them something. So let me see somebody else. No vitamin C. Yeah, oral care, flossing and other thing, they're going to bleed back. You give them folic acid. Folic acid. Remember folate. When you're taking somebody is pregnant and then they're already taking in order to prevent neurotube defect, we give them folate. That's what this medication do. It's the same thing. So give them folic acid. That will help with the gingival hyperplasia. Very good. It's a sulfur drug. Stevens-Johnson syndrome is your normal. It's your B-sharp movement. You got to see this patient. That's bad, right? I love this drug because it's a testable question. They have so many things they can test you. IV infusion. Guess what? Bad. It causes bradycardia and dysarrhythmias. Therefore, you should avoid it in somebody with a heart block or already have a Brady issue. It causes severe bradycardia through IV infusion. How do you prevent it? Don't go more than 50 milligrams per minute. This is key. So IV infusion of phenotime can cause this problem. So avoiding somebody a heart block, you should avoid it. To prevent it, just run it slow. Okay, run it slow. This is the if I'm examining, I mean, it has so many things that you can ask about it. Avoid glucose. You cannot infuse it with the glucose. Therefore, what solution we use? Isotonic solution. What is isotonic solution? 0.9% normal saline and LR. This is what you can infuse it. And when you're infusing, making sure you're not getting 50 milligram, more than 50 milligram per minute. Otherwise, they get into trouble. Okay, so no glucose. Then tube feed. See, I know you've seen questions about tube feed. He hates protein. Phenotype hates protein. Protein affect absorption. So if somebody is on tube feed, you're going to give them phenotype through a PO form. Yes. Hold tube feed 1 to 2 hours before meds, then resume feeds 1 to 2 hours later. Keyboard testable question. They like it, hold it. Because he hate protein. Guess what? If I give you albumin, yeah, therefore you should not transfuse this through an albumin, right? He hates glucose and albumin. So if I see, I said, I think I have a question on YouTube. Which of these you should avoid when you're infusing phenotype? Yeah, no glucose, no albumin, but you can use normal saline. It's very, very good. It's also teratogenic, and glucose, you should avoid vitamin K factors. It affect your coumadin too. So coumadin become ineffective due to vitamin K. So it can affect your vitamin K level. This is stuff that you need to know. I think I said about teratogen also. It can cause cleft and palate problem and then a heart problem. But this is everything about this track. Okay, I'm back. So let's clean this. The next drug is antipsychotics. I think this is the one that always scares people. Um, there is a first generation versus second generation, and there can be third generation, but some people have not divided them. Okay. What are these used for? It's for psychotic issue. Okay. Um, you can use it for acute and chronic psychosis, right? Schizophrenic and the spectrum. And spectrum means autism, all those things you can use this in Tourette syndrome, or the spectrum. Yeah, you can use it for maniac patient. So like bipolar, if you get into trouble. You can even use it in chemotherapy for nausea. So very, very good medication, except there's a bunch of them with different side effects. The first generation, which are, you have to know the difference, which are typical. They were the one designed first, but they have bad side effects. And so we've stopped using them as a first line. No, no more first line agent. Usually when somebody is agitated, you want to use it, and that's when we try to bring it and use it. But we don't use it that much anymore as a first line agent. Why? It causes a lot of problem. It causes a lot of problem. The number one is, and that we see that is not too dangerous, is extra pyramidal syndrome. This is why and your board like it, but it's very common. Okay, so this is why we use it. That they like to ask you about it. And there is the way to remember them. I call them adapt. It's okay. Acute dystonia, akathisia, Parkinsonism, and tardive dyskinesia. These are the EPS. You have to know the definition, what it means, and how to treat them. But before that, you have to know the drug, the first generation. They are weird, but you can figure out. Some of them have the last name Zing, Zing, Zing. The common one is this haloperidol. Everybody knows it. Do you think they were going to give it to you? No, right? They're not going to give it to you. Look for those which as last name as Zing, 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 like chloropromazine. One of them. Perfenazine. Another one of them. Right? Flu. Somebody told me to get this one. Phenazine. One of them. Right? Trifluoroperazine. Another one. No, that's not how you spell it. UOO perazine. Another one of them. And there's a weird one, lozapine. This is it's different. It looks like a marzipan, but it's different. It's like he has his own thing. It's a new one. When they have different rare name, you can see that this is like different. And this is the most common. Sometimes you see it in the text because it's also weird. You can't figure it out. Autism. These are 1, 2, 3, 4, 5, 6, 7 medication. If you wake up in the morning every day and you try to remember them, you keep on writing them, the parcel, and keep on circling them, add more to it. The first page, the what I did not have all of them, but you can write all the medication in one page and circle. You'll be able to memorize them and say, oh, this is the what it is, because all of them have the same side effects. So you don't have to memorize specific side effects for this ones. Okay, these are them. Okay, let's get to the what they like to ask you. Acute dystonia. This is like severe, painful. It's painful contraction, muscle contraction. Basically, it can involve your tongue anywhere, your back anywhere. It can involve if you involve your laryngeal muscle, yeah, it's a big sharp movement. That's the way they describe it. Patient has a severe painful contraction of their back, their tongue, and everything. What they want you to do, identify it and treat it. Treatment, anticholinergic, benchtropine. That's number one. Guess what? They may not give it to you. Look for Benadryl. Can be used for it. Another common anticholinergic, triaxiphenadol, is what they also like. You may not have seen it before, but this is some of the anticholinergic we use when you have this problem. Right? These are the common ones. They will get benchtropine, diphenhydramine, and triaxiphenadol. That's what you can use. There's other ones, but these are the three you can use for acute dystonia. This usually occurs just 4 hours. As soon as you give it to the medication, this is number one you should be watching for. 4 hours, you can get 4 hours to 5 days. The number one symptoms is acute dystonia for EPS. If it doesn't happen within 4 weeks, yeah, watch for Parkinsonism. This patient has Parkinson. You know what you expect, right? Slow, everything is slow. Bradykinesia, right? Bradykinesia. They're going to be drooling. They will have rigidity. They have no fever though, so that's not a problem. They will have shuffling gait. You're making them Parkinson, basically. And they will have resting tremor. These are the key buzzwords when you hear it in the question. Somebody give you antipsychotic, first generation, all of a sudden, they're very slow, they stood up, they're drooling, they're stiff, they have resting tremor. That's Parkinsonism. How do you treat it? Same thing. Give them anticholinergic. Those that I've listed above, these three, I'm not going to rewrite it. These three, I'll put it here. But there is another one, you can give it to them. That is classic for um, Parkinson. We give it to Parkinson people. So I'm giving you all so that when they don't, you see the answer, you say, oh, there's no benstropine, diphenhydramine, or triacylphenidol. Yeah, this one, you can give it to them. Amantadine. We use it mostly for also a Parkinson patient. So you can add this to that and they will be fine. So that's the treatment. Same thing. 4 weeks. If it happens in 8 weeks, be watching for akathisia. What is this? I call it bipolar part 2. They feel like they got to keep on moving. They can't stay one place. Restlessness, inner feeling of had to move all the time. They can't stay still. They'll feel like they're agitated, but they are not. So agitation. So look for agitation. They are not. They just like cannot stay still. Can't sit up. You feel like I got to keep on moving. Like a bipolar like symptoms. What do? Same thing. Benstropine, diphenhydramine, triacylphenidol. If you have amantadine, you can give it to them. But what is the good medication for this? If you don't see it, beta blocker is excellent. It will calm them down. Beta blocker can do the same thing. It will make them calm down. So you can give them beta blocker with that in it. What else can put you down? It's a downer. Benzos. You can give them benzodiazepine, diazepam. You can give them and that will do the thing. So if you see a benzo for akathisia, pick it. If there's no any other answer choice, if you see a beta blocker, yeah, it's not wrong. Don't. So that's why I give you all the answers so that you can, you be efficient. Okay, so I get it clean. This is gone. That's akathisia. Then tardive dyskinesia. This is different. It's not painful, but it's scary. You see their neck move on one side. Okay, so these are involuntary movement. It can involve any portion, the tongue, their face, and you see some lips barking. They will show you their tongue. Yeah. And they're moving their leg in a different way. Yeah, that's tardive. And usually this takes some time to occur. It takes some time, months to years, for it to show up. This is the problem. It can be like a very priority because it can affect their speech and they cannot eat. So you have to patient and their movement. So this is like a priority. When you see that, we got to fix it right away. You have to change the medication, move to another one, but you can treat it with any of this temporary. So treat it with the same medication, anticholinergic we talk about. So any of them. Okay, so that's EPS. They'll describe one of them and then you figure out and you just pick the answer choice. It will be a medication management. What is the worst one of this medication? Is neuroleptic, I think it's neuroleptic malignant syndrome. This look like serotonin syndrome. What is the difference? Big difference is I did not give you SSRI. That's the key. So don't let this trap you. I gave you what? Antipsychotic. I gave you lorazepam. I gave you phenacin. I give you allopurinol. I did not give you fluoxetine. Don't make it too hard. I did not give you sertraline. So when you see the question, see what was given, classify it into one group. If it's a SSRI, it's a serotonin syndrome. If it's antipsychotic, whether first or second generation, it's a neuroleptic malignant syndrome. Because the symptoms are the same, you give it to them, temperature, everything is up. What is the problem? Temperature 104, tachycardia, they're sweating, they have muscle rigidity. You don't know, but you have to pay attention to what was given, and that's your answer. They have loss of consciousness. Your treatment, I call it cooling me down, baby. Cool the patient down. So whatever you're going to cool, is cool them down. They have to be in the ICU. You have to give them fluid. And the key is the muscle. We got to stop muscle contraction. And the medication you see on your board is this, dantrolene. If you don't see it, look for this, bromocriptine. I don't like giving you one answer. Try to give you more than that in case they trap you. Oh, I don't see dantrolene. Yeah, you see bromocriptine there. That's your answer. The patient is in the ICU. That's all. Neuroleptic malignant syndrome. These medications also has anticholinergic effect. We're not going to talk about them anymore. We've had enough of them. They call it orthostatic hypotension. They have so many side effects. Expect sedation, you get drowsy, so you take it at night because it's sexual dysfunction. They don't ask you too much about this. They ask you about the NMS, EPS. That's the very this thing. It can cause agranulocytosis, but it's common for second generation. I expect that it can happen. It can cause Q2 prolongation, but it's more common in second generation. It can cause liver damage. I'll circle those you have to know. And what you have to avoid is caffeine and dopamine, levodopa. They're blocking the effect of dopamine. So if you take anything that will give you dopamine, it's a problem. So that's why you should avoid levodopa. Caffeine increases your dopamine. So we make the medication does not work. This is a what happened? People think the stigma, no addiction. It does not have, you don't get addicted from antipsychotic. So there's no addiction associated with that. But all these things can happen. What they like is the EPS and the NMS. But we pay attention to anticholinergic, orthostatic, agranulocytosis, and QT. It can also happen, but mostly in the second generation. Okay, so that's the first generation. Second generation, they too, they have their own thing. These are now the first line treatment for psychotic problem. First line, more effective, side effect is minimum compared to the first generation. There is a bunch of them, but don't worry, they have last name as Don, Respiridon. Try to be familiar with them. They have Dons at the name and P. Zaprasidon. I'm putting them together if you're taking a picture. Okay. Lurasidon. You see, they all have the last name. Palapiridon. Ilopiridon. Are you tired? Yeah, those are the Don family. Then Zapin, Olazapine, and Chlorapine. Those are the family. Then the Zor, there is a Zor family. These are the new one. Piprazole. This is Abilify. This is usually considered as a third generation. Praziprazole. These are new ones that are coming. They call them third generation. This is the family. Then this, I don't like it. Asanipine. Because it's off. You just have to, you don't know where you want to put it. This is also another antipsychotic. And quetiapine. I like this one because it makes you quiet, quetiapine. That one you can record. These are the strange ones. But these ones, the Dons and the pins, you can figure out. And the Zors, these are like the new third, aripiprazole, the Abilify. These are the three ones they are the third generation that are coming. But these are most of there's another one, cariprazine, but don't worry about it. These are these common one. What is the problem with this? It's the same thing. You don't have to learn anything. The first generation block, so first generation, they block mostly dopamine. These second generation block mostly serotonin, but they all block the same thing, but they take more attention to that. Therefore, they have fewer EPS, extrapyramidal side effect, NMS, okay, and tardive dyskinesia. So the side effect is very lower than that one, but they can cause it. So if they give you a medication, it's a second generation, and it has EPS symptoms, yeah, don't say, oh, this is not a first generation. They too can cause. They can cause the same thing, the same antipsychotic. The way I like to do it is to give you key facts about them. Olanzapine. What should you know about this? For all of them, weight gain, hyperlipidemia, diabetes, you should not forget. So this is the key. Olanzapine is a classic number one. So it does not have too much except this. Weight gain, hyperlipidemia, and diabetes doesn't have any unique thing associated with it. Quetiapine, it has something associated with it. What is his problem? Cataract. So you should tell the patient need high screening, right? That is all I'm going to say about it. Zaprasidone, what is classic that we all know, it also causes weight gain, hyperlipidemia, all of them. You always go back to olanzapine. Say olanzapine causes weight gain, hyperlipidemia, diabetes. Quetiapine also do the same thing, weight gain, hyperlipidemia, diabetes. But classic is cataract. Zaprasidone, weight gain, hyperlipidemia, diabetes is QT prolongation, which can lead to Torsades de Pointes. And you treat this with what? Magnesium. Right? You know this because everybody talk about it. Clozapine. It's the same thing. Weight gain, hyperlipidemia, diabetes. I'm not going to type it. But what is key about this? Agranulocytosis. Also causes QT prolongation. Asanipine, the one that I hate, QT prolongation. Right? And then the Abilify is the one that just came. Aripiprazole. This is the best that we've produced so far. Okay, less sedation, but it causes some insomnia, and it does not have too much side effect. No QT prolongation, even is minimal. All the side effects are minimal. So this is the best we have so far. All of them, all. I mean, all. All avoiding pregnancy and breastfeeding. All of them, because it's problem. All of them causes that problem. And then risperidone is like it does not have anything special. It do the same thing like that of the olanzapine. Olanzapine, weight gain, hyperlipidemia, and diabetes. Uh, if you see a question of breast in men, gynecomastia, and lactation, galacturia, because of increased prolactin or antipsychotic, that's that. This is key. So don't freak out. It make them grow boobs and they lactate because endocrine, that's the one endocrine. All of them is not unique for anybody. All of them do that. The other thing too, all this QT prolongation I talk about, the first generation caused it, and second generation does that, and a few of them, you know, in order to avoid this, we should avoid what amiodarone causes QT prolongation. You should avoid macrolides because it's QT prolongation. TCA, tricyclic antidepressant, also do that. Low magnesium causes that. So all these things can cause QT prolongation. So when you see that in a question, don't say, oh, I don't know it. This is antipsychotic. Just group them, know few specific about them, and you'll be fine. We'll do a question. You see that it's not that difficult. And the last ones are the benzos. Anxiolytic. What is that? Anxiety, right? They if the anxiety means everything is happy. We want to slow you down. The same thing like the mood stabilizers, they all act on the GABA to lower you down, inhibiting effect. They very bad medication, so we use it for short-term use. Why? Dependence and withdrawal symptoms. We have a lot of it, so we stop. We try not to put you on it too much, okay, because it causes so much problem. We use it for panic attack, generalized anxiety disorder, muscle spasm to relax the muscle. If you have seizures, we will relax you. That's why we use them for acute seizures. It will put you down. They are downers. Okay. What are they? Some of them are recognizable, some are not. We have the Pharms and the other one. So lorazepam, number one, right? You can see that, right? Oxazepam, right? So now I'm trying to say it so that you can see. Pharm, the Pharm family. There's some that you have to like memorize them. Chlordiazepam is different. It has its own, but they like that, you know, because it's weird. But it's benzos. Okay, it's a benzo. And this one, chlordiazepam, dicipate. This is usually common use for alcohol withdrawal. You know, this is what if you're having alcohol withdrawal symptoms that you're going to go seizures. Usually they try to choose this, but you can use any of them to help you. They are downers, so central nervous system depressant. I don't have to tell you what you should avoid. Avoid anything, alcohol that will make you go down, right? Or anything that will make you go down, you should avoid it. It causes respiratory depression. We have a problem. Is a downer, right? If that happens, what is your antidote? You have to know this. Flumazenil. Know this antidotes for benzos. They have to have it available all the time. Key fact is a downer. If you are intoxicated, everything is down. That means if you take too much benzos, I should see what bradycardia, saturation going down, right? Everything is going down. I should not be seeing things going up. That's the key when you ask you a question like that. If they tell you they've stopped taking their medication, a downer, and you have withdrawal, symptoms should be going up. So your symptoms should be going up. Nausea, yawning, diarrhea, all those things. This is what you're looking for in a SATA form. No pregnancy. No breastfeeding. Contraindicated. You should avoid it in grape. Very bad. It make you worse. They don't like anxiety medication. Grapefruit juice, you should avoid it. Is a downer. When do you want to take it? At bedtime. That is benzos for you right there. Of course, everything there is a weird one. There's atypical anxiolytic, like bupropion. They like this one, like bupropion, but it's not a bupropion. Atypical anxiolytic. It look like bupropion, but it's not. It's a bus. I call it bus. The bus. Buspirone is a bus. Think about it. I'm a bus. I can take you anywhere. This is the key. This is the only way I can remember is if you see S, it's not bupropion. Bupropion is for depression. It's atypical, but this one is the bus. That means it can drive you anywhere. What does it do? Serotonin and dopamine. But because I'm a bus, I can take you anywhere. No sedation. Watch this. This is the trap. No sedation, no dependence, no withdrawal symptoms. Wow, we have a benzo that we don't have withdrawal symptoms. Guess what? We're going to love you. That's why they love it. Buspirone is like bupropion. They also have their own side effect. You got to weigh the risks and benefit of it. But no sedation, no dependence, no withdrawal symptoms. Like bupropion, it takes like 2 to 4 weeks to work. You see, it sound the same thing, right? The story is sounding the same thing. Like bupropion, there is suicide ideation. So you pay attention. Like bupropion, you should avoid SSRI because it's serotonin, right? SSRI, SNRI, and you should avoid grapefruit juice and St. John's. What? The same thing like bupropion. But it's very, very good medication. Very, very good. And they like it. They will ask you that. If they're going to have anxiolytic, because they will trap you in a certain form. Like you should not worry. Um, you should not worry about it. So suicide, you should not worry that it's going to be dependence. No, it does not affect dependence. It has no sedation, no withdrawal symptoms. And then since he has none of this, well, you can take it anytime. Take medication anytime you want. Anytime. And you can drive because it's not affecting sedation. Except it takes some time to work. That's the only problem. 2 more medication. I will let you, then I'll leave you guys alone. Zolpidem is also atypical, anxiolytic. It's non-benzo, atypical anxiolytic. I don't want you to mix any question. That's why I'm doing this. It's a short-acting medication. But what is very sedative compared to buspirone. It's a bus. Buspirone is the bus. It will drive you. It's not sedative. This one is very sedative. So that's not how you spell it. Zolpidem. Oh, sorry. So ZOLPI. So it's very sedative. Guess what? When you take it at night, why? Good for insomnia. So we can use it to treat insomnia, zolpidem. So that's the common prescription for that. Older patient can sleep. Yeah, give them zolpidem or metazapine or trazodone. Okay. Side effect: sleepwalking. key for this medication, which he has somnambulism. That is basically sleepwalking, because it's sleepwalking. So what is your problem? Safety issue for that. Safety issue. That's the only thing I want you to pay. It's very, very sedative. Can be used for insomnia. It's anxiolytic. You take it at night. And I want to do one more medication for kids. This you have to know because your body like it. It's a stimulant. And they use it for ADHD. Very, very good medication. It's a stimulant, but it makes these kids really down. Guess what? If they don't put it there, it's fine. If you see amphetamine as the answer for ADHD, don't say, oh, I don't need it. It's the same, methamphetamine. It's the same thing after amphetamine. If they don't write it, sometimes they make this hard for you. Listen, you get confused. What are they talking about? You see this medication? Look at what I'm going to. Liza, right? Amphetamine. I'm using the last name, the same last name. Don't forget about it's a compounded medication designed to confuse you, but look at the last name. They all look the same. That means they do the same thing. If they don't give you that, they will give you this. That's true. Do you have to worry about it? I'm going to write the same thing. Amphetamine. Same thing. They all do the same thing. We give it to kids for ADHD, right? It's a stimulant, right? You want the things to go up, but for these people, it calms them down in their emotion. They can do the biggest side effect, biggest. It looked like bupropion, anorexia. So I'm not eating. So you should avoid it in an eating disorder. Who will benefit from this? Obesity. So if you're obese, I give you amphetamine. Yeah, that's right. People who do those drug people who do this drug, they also look skinny because they don't want to eat. You decrease your appetite. So if you're obese, we give it to you, well, you lose weight, right? It's very, very good. Because of anorexia, we have like weight loss. For kids who are still growing, you want them to lose weight, it affects their growth. So that is key. They lose weight and they affect their growth. If they come to your clinic, number one, question you ask them, you have to keep on seeing how the kid is eating. Know about their eating pattern. Getting good nutrition, okay? High protein, so that you can grow. And what do you do in the clinic? Check their height and weight. Very key. If they're losing weight, we have a problem. We got to fix something. So you the nurse, somebody with ADHD coming on methamphetamine, the number one thing you have to do in your clinic, make sure you checking their weight and their height. Is very, very important. Very, very important. It has a side effect, other side effect that you don't need to worry too much. They will give it to you, but they won't actually. It can cause headache. Your blood pressure can go up. You'll become restless. But teaching intervention is this insomnia. So what do you tell the mommy? Take it before 6 p.m. Otherwise, we have a problem. If you take it at night, yeah, the kid cannot sleep. They can also have hallucination and other things, but these are all things you have to know. Insomnia, so take it before 6 p.m. We can have headache, hypertension, restlessness, but those one we can follow. Check their weight and their height, making sure the kid is getting good nutrition, and set a eating a pattern so they can eat regularly so that they can gain weight, but they're going to lose weight. They're going to trap you. They're going to like make it hard. They're not going to give you easy ones. Sometimes they give you methylphenidate, but they give you this. Let's this amphetamine or detroamphetamine. They are the same. Don't worry about it. They're doing the same thing, the same teaching you provide. And that is the end of everything. So that is that. Let me just stop recording.